Hi, this is Duncan Ferguson. This is first of three videos where I'd like to talk about the treatment of selected organ system infectious diseases. And this is hopefully going to be a sort of a turnaround for what you might have learned in your standard classes about bacteria, what antibiotics might be used to treat those bacteria. In this case, we're going to sort of look at the odds about the actual bacteria that might be the biggest problem in a certain organ system, and then we're going to go and start looking at the antibiotics, their ability to get to that site and treat the condition. So the three sections, the first one will be on circulatory and dermatological or even wounds. The second of the series will be on urinary and reproductive infections, and the third will be on respiratory, neuro, and bone infections. Before going too much further, I'd like to recommend a resource to you that I found very useful, particularly in small animal infectious disease management, particularly bacterial disease management, and also in exotics as well. And this would be the target reference, and it's a book that is compiled from the experience of, I believe it's Antech Labs by Dr. David Aucoin, a clinical pharmacologist, and it basically looks at the likelihood of certain bacteria, the likelihood that certain bacteria will be treatable by antibiotic, and also a little bit about their cost. So I think it's very practical information and something that gets us to thinking about that many of the times, at least initially, we have to use empirical guesswork to sort of pick the right antibiotic until, or even if, until we have a bacterial culture result. In the meantime, take what I'm about to tell you as really a first guess, empirical selection of the antibacterials based upon the likelihood that a certain organ system is affected by a certain bacterium. Always, information from culture and sensitivity should take precedence. So I'm going to put this in the beginning of each of the three units to make this point very strongly. So let's start with the general infection of the general circulation. Sepsis might be another term for this. And basically the important thing here is it's because it's so hard to get a blood culture, a positive blood culture, you really need to look for the source of infection. So, and when you do, you do it through history, you look at the animal very carefully, you try to determine if there's any trauma, and then if that doesn't work, you're really following you probably have to go for multiple blood cultures, both aerobic and anaerobic. If you have intestinal trauma, you can assume that you have a mixed bag, really, of gram-positive, gram-negative, and aerobic organisms. And so this generally will lead to what we call the use of four-quadrant therapy to address all of these organisms. So what are the bad actors with regards to bacteremia or septicemia? Well, they are staph, strep, E. coli, Klebsiella, Enterobacter, and Pseudomonas. So anytime you have a septicemia or bacteremia, this is a very serious condition and you really do need to go for a culture. Many of these have significant resistance issues with them. So just be in mind that these are the most likely bacteria that you'll be encountering. Let's talk a little bit about anaerobes. Anaerobes are going to be not uncommon at all when you have oropharyngeal, pleuropulmonary, and intra-abdominal infections. In fact, about 25% of these infections will involve anaerobes, and Bacteroides is the most common. Of course, the therapies for these I've put underneath, and you can read through them. Clavulanic acid, amoxicillin, or clindamycin generally have a reasonably good spectrum against anaerobes. For those procedures, if you're doing surgery near the alimentary tract and there's likely to be a breakdown of the blood-gut barrier, you need to consider the possibility of using at least managing gram-positive and gram-negative, if not also anaerobes. And so I've given some suggestions here. So the aminoglycosides and cephalosporins, various types, would be a good combination for this. Let's look at bite wounds specifically right now. And what you're dealing with here in most cases we're going to be strep, Pasteurella, or penicillinase producing staph. And the drugs of choice here would be clavamox or clavulanic acid amoxicillin, and other drugs that have protection against the penicillinase producing bacteria, such as oxacillin, dicloxacillin, or some of the cephalosporins, tetracyclines, and quinolones, and sulfa drugs, sulfa-trimethoprim. Let's look at traumatic wounds or abscesses. Generally, these can be managed with clavamox would be one choice, or the quinolones, and enrofloxacin, marbofloxacin, predafloxacin would be good choices depending on which ones you have available to you. What about skin infections, pyodermas? So I think it's worthwhile distinguishing between the superficial and the deep pyodermas. And in either case, we're probably dealing with coagulase positive penicillinase producing staph. And now today you need to more and more consider the possibility of significant resistance, such as methicillin resistant staph. And it's now known that these can pass between species. With deep infections, you may then get into some of your gram-negative organisms, fungi, and mycoplasma. The important thing about these is to notice and recognize that they are microabscesses. That means that you have to get the drug into these microabscesses and treat for a reasonably long period of time, even rotating drugs between various types of drugs with different mechanisms, different toxicities, to avoid resistance. And so you have to get the drug to the site. With skin infections, we're almost always dealing with staph at one point or another, and this is likely to be staph pseudo-intermedius in small animals rather than staph aureus. They have relatively predictable susceptibility to beta-lactamase resistant antimicrobials, such as those with a beta-lactamase inhibitor, clavulanic acid amoxicillin, or some of the synthetic drugs like oxacillin. You also can go for first-generation cephalosporins, such as ceflexin or cefadroxil. So how do you treat empirically a skin infection until you have a culture? Generally, we recommend that you get a culture from some site, whether it be a pustule or a scraping or whatever. And let's start with the second point here, that we have, in the old days, I guess 20 to 30 years ago, erythromycin and lincomycin, the macrolides, could often be used as a primary choice, but we need to know that when there's resistance against one, don't go to the other, because these have similar mechanisms of resistance. Going to the top, notice we have the clavamox, we have dicloxacillin, oxacillin, and then certain cephalosporins. We mentioned erythromycin, lincomycin already. Probably is becoming back to the fore is trimethoprim sulfa, and of course any of the quinolones.